Welcome to yet another episode of the Health Court podcast, where we have expert guests conversations on all matters health and lifestyle. My name is Joan Kasim. Today's episode is very interesting because I think in a way it's personal for me. You know, when you reach the age of 25 onwards, or even 27, 28, you start considering starting a family. Now, one of the commonest things that I've seen happen in our age and era now is before we start families, we usually go for pre-marital counseling, which is common in both communities, the Christian and non-Christian communities. They help couples transition into their new roles as husband and wife. The one I've not seen, and the one we are going to be talking about today, is pre-pregnancy counseling or pre-pregnancy preparation talks. Now, which I think is very important, and I think it also explains why we have so many cases of new mothers facing very many difficult challenges because they did not prepare themselves. We've heard that every pregnancy is different, which is true. Just like marriage, every marriage is different, yet premarital counseling is important because that foundational knowledge makes a very big difference. Now, before we get into the topic, I'll let our expert of the day introduce themselves, tell us who they are, what they do, and where we can find them.
Hello, everyone. Thank you for tuning in, and I welcome you on our podcast to talk about my favorite bit. That is women, ladies that are thinking about bringing life into the world. They're considering the hassle of having that baby inside them. They are considering the hassle of childbirth and taking care of that baby. You're welcome. I am Christine Nanyonjo. I am a midwife, a practicing midwife, a very passionate midwife, very passionate about maternal health and child health. I'm currently working with Chitebi Medical Center, what Dr. Mwanga, that's what we refer it to. You can find me on my social media handles, Instagram, that is Tina Nanyonjo, and on TikTok, it's Tina Nanyonjo, your midwife. Thank you.
Thank you so much, Tina. Now, we are getting into the questions, and the first question that I'll ask you is, have you ever offered pre-pregnancy preparation talks, especially to new couples? You know, usually when we are talking about preconception talks or pre-pregnancy talks, we are talking about those couples that have been trying and maybe have failed, and now they've come to the medics for help. I'm talking about these ones that have just come. We are just beginning our family and we want to know everything that pertains that.
Okay, well, thank you, Joanne. Being a health practitioner, a midwife in specific, and a practicing one in specific, that is one part that you can't go without. You will find this everywhere. As long as you're in practice, you're dealing with patients, and you're interacting with people looking at family. So yes, to answer the question, I have done that.
And okay, now take us through. For example, now, being me, I would like to also have that knowledge. Like before I consider a family, what should I look at? If I start my pregnancy journey, conception journey, what should I look at? What do you take us through when you're preparing us through that topic?
First of all, when you talk about preconception counseling, we are looking at you've decided you want to have a baby, but you want to get the baseline knowledge. What should I know? What should I expect? What should I avoid? What should I improve? My number one tip, I would want to have this mother or this lady with their partner. It will be an honor to have our partners coming along with us when we are seeking this kind of counseling. Why? Because we have a session whereby I'm going to talk to you as a lady, a session where I'm going to talk to you as a man, to this lady who is planning to be pregnant, and a session where I'm going to talk to you as a couple. Because one of the things that we put emphasis on in reproductive health is male involvement. We want to have our dear men, our partners, our husband, whatsoever. But I should also say that there are not yet very many, because single mothers just end up there by circumstance. So most of the people that come in planning to conceive, they have had a discussion with their partners and they have agreed upon this decision. The ones that come may be those ladies that have made so much money and then they just come in, I just want to have my child for me. I don't want a man and stuff like that. But as for this session particularly, let's look at a couple.
Yes.
Are we right there?
Yes.
Preconception counseling, there are very many things that we talk about. Most of it is educational. Like I am talking to you, you're talking to me, because counseling is a two-way. I give you the information, you ask me of what maybe I didn't elaborate more or something like that. One, as we going through dating, as we going through courtship, and we have agreed to be a family and to bring a child in this world, at least one of the things that we do is HIV.
Yeah.
At least thank the government that has done so much emphasis on HIV and whatsoever. So we are conversant with that. Let us go for the testings, not only the clinic testings, but thorough tests. Let us go to those diagnostic centers. We can look at those big hospitals, Ebenezer, Lancet, and whatsoever, to have the serious tests. That is for HIV. Number two, we're going to look at STDs. All these, just a disclaimer, all this we are putting at the back of our minds, how they are going to affect the mother and the unborn baby. So after looking at HIV, let us also look at STDs. There are very many. They are very various.
You know, when you talk about STDs, we usually think of AIDS. Not even the infection, HIV. When you think of AIDS, which other STDs, now that you've brought them up, which other STDs are really a risk factor for mothers or for pregnant women? Maybe you can give us a brief of those diseases. Okay.
Just to put it right, all STDs
Yes.
are risky to pregnancy and to the unborn baby. Apart from HIV, because at least we've had the awareness about HIV, we look at gonorrhea. At least a largest part of the general population in the men know about gonorrhea. It is an infection not to laugh about. Ladies, we can have it for a period of a month or two without adverse symptoms. But men, you have gonorrhea tonight, next morning, trust me, you're going to be in the hospital. Yeah, we can look at syphilis. Gonorrhea is adverse, so people seek treatment. It is not the same for syphilis. The symptoms are subtle. They can be neglected before it rises to be so complicated. So that is also one of the things that we look about. Then we can go into the genital warts, we can go into candidiasis, we can go into chlamydia, chancroid. Now those ones are more conversant with people who have had them and they have gone there. But in the general population, we want to look at HIV, gonorrhea, syphilis. Those three are the biggest problem in the general population. Yes. So STDs, I mentioned earlier that they are going to complicate pregnancy. They will complicate your ability to get pregnant, or even after you're pregnant, they're going to complicate your journey to the point of passing it to your baby.
Oh, yes.
Yeah, so STD should also be something that we should be looking at keenly when we are looking at conceiving.
Conceiving, yes.
Yes, and when STDs aren't treated, they'll develop into what they call a PID. I don't know that you've heard about that.
What's that?
A PID is just a complication of the STDs. Like you've had your STDs, they have not been treated, and then they rise. PID is pelvic inflammatory disease. Usually, these infections, if you're looking at the female reproductive system, for example, they are below the cervix. They're affecting below the cervix. So by the time it gets into a PID, it has crossed to the cervix, it has gone to the uterus, it has gone to the fallopian tubes, it has gone to the ovaries. Now, those are vital organs as far as childbirth is concerned. So when the infection crosses to that side, it is something else. Yeah, and urgent treatment will be needed. So let us go for the STD screening alongside our partner. Because one thing we talk about is you'll be treated, but once your partner is not treated, you've not done anything.
Yes.
Because anytime they're passing it on. Yeah, so that is it for STD. We talked about HIV, STDs. Number 3, sickle cell. Yeah. Yeah, sickle cell. There are campaigns that the Buganda government keeps on having against sickle cells. I don't know whether they're still ongoing.
Yeah, it's still ongoing. It happens at least
sickle
yearly.
cell run, something like that. Because back then, they used to think that sickle cell is a traditional disease, like those things. But people are getting to the awareness that it is known, it is in family, it is running in genetics, and at least so let us go also for the sickle cell screening. Once you find out you're a carrier, your partner is a carrier, the best advice we're going to have for you is to break up.
Now, if one is a carrier and the other isn't, can they still be together?
Yes, they can be together, but they have chances of bearing a carrier. Just to be more specific, in the population, we have the ones that are normal, that they're not having the gene for sickle cell. We're having the ones that are carrying, one of the chromosomes has the gene for sickle cell, and then the ones that are sicklers. So the problem, the normal ones, it is okay. The sick ones are getting the treatment, though life is hard for them.
Sure.
If you've seen one, life is hard.
Yes.
At a personal level, I am a carrier, and I have siblings that are sick. Yeah, like 2 of them. And actually, for that reason, I've developed a lot of interest in sickle cell one and awareness. Actually, that is one thing that I do immunization. Yeah, that is one thing that I tell my mothers about. Yeah. So sickle cell, once you are a carrier, you meet a carrier, you're definitely going to have a child having sickle cell disease. And if you have been in an environment that has someone with sickle cell, you don't want that for your child.
Sure.
I have a scenario that I had some time back at the facility. We had a couple. They came in and they were screened, and they were both carriers. We did the counseling. One visit, the second one, the third one, the fourth one, they agreed they couldn't break up. We advised, we gave examples, we did whatsoever. They couldn't break up. And it is very unfortunate that they ended up having the firstborn as a sickler, the secondborn as a sickler, the thirdborn as a sickler, and the fourthborn. These kids go through a lot of pain.
Very true.
These kids are expensive. Trying to seek treatment abroad where they are doing a bone marrow transplant. It is expensive, and the chances of success are low.
Very low.
So it is not a question of you can afford or not. You'll have to spend time with this child. If they are school and it's boarding school, you're going to be calling in every day. How are they? If the weather gets berserk, you have to call in. So it is a lot of work and pain that you don't wish for your child.
True.
So when we advise that, please get away of finding another partner, please don't.
Or you can even choose not to have kids.
As per our tradition as Africans, I don't know what you're going to tell mommy and daddy that I do not want to have kids. That is something else. But going back to the point, sickle cell is serious, and those are one of the tests that we highly put emphasis on.
So you as a carrier now, because you've given us an example that you're a carrier, what kind of partner would you get? One that doesn't have it at all?
Completely normal.
And then what are the chances that you might have a baby that is a sickler?
0.
Or a carrier?
Carrier, their chances. It can be a 50. Yeah. So if you are a carrier, you're supposed to go completely normal. Actually, with me, who has the experience from my family, and I have seen the kids, how they fare their lives, those are one of the things that I do first. We're going to do HIV, we're going to do sickle cell. That is a must for me, and other STDs.
True.
So, yeah, we talked about HIV, we talked about
STDs, then
sickle cell. Number 4, blood group.
Oh, yes.
Yeah. Amongst the many tests we do pre-conception, because as we are counseling, I'm going to, like the way I'm talking to you, I'm just going to talk through them. And then the next step is to advise you to go for these tests. I would recommend that you do them that very day. Because once you step outside of the facility, maybe other things take your mind. Exactly. Yeah. So, blood group. Unlike the rest that we have talked about, blood group has a low awareness rate. Like, people don't know about that. There are very many misconceptions about blood group. I hear when you can't get sick, what those things. But those are misconceptions.
You can't get any sick.
You have all,
so many
you're stronger. Everyone, I think that is from our primary. Around physics, when they draw that little thing that they're saying, is a universal donor. So, if that is a complete misconception. Yeah, so blood group, what are we looking at in blood group specifically? It's not about, we're not looking at whether you're A or O or B or whatever. We are looking at what we call rhesus factor. It is not common in the general population, but when you go to the health workers, many of you who have done blood group, they have told you you're B plus or B positive. Okay, let's say B plus. Maybe you're A plus. The biggest part of the population, they have the plus. But there are those exceptions that have the negative. And that is where our emphasis is. O negative, A negative, B negative, AB negative, we're having issues. I am not saying you're sick. I'm not saying you have anything wrong with you. We just have, it just raises some concern as per your healthy worker, like the person that is working on you. Among the things that we give information about when we land in the hospital, apart from drug allergies, whether you're pregnant or not, whatever, is blood group. Especially when we are looking at the maternity side. Rhesus, we call it rhesus factor because your blood has that antigen and whatever. That is a lot of science. I'm not going into that. But once you are negative and you are a mother, the good part would be if your partner is negative. But remember,
once you're negative, your partner should also be negative.
Exactly. For you to be fine, not for you to be fine, for your babies to be safe. But remember, we said that 80% of the population are positive. It is only 20 that is negative. So if you're negative as Joanne, that means there are higher chances that your partner is positive. It takes me back to what I said, that when we're looking at maternal health, we want to have the men involved.
True.
Because now if I do not have your partner with you, when you've come for the clinic, for the preconception counseling, how are we going to get to know? Because blood group is the last thing that people think about.
True.
So how are we going to know? How are we going
Personally,
to
I haven't thought about it for the longest time.
Exactly.
You think about the sickle cells, the HIV, the STDs, but that blood group is something that comes up later.
Exactly. Actually, it first raises complications, and then you hear your health worker talking about, and you're like, by the way, what is my blood group? You understand? So rhesus incompatibility is where we are having our mother, our pregnant mother, or our mother that is planning to conceive, be rhesus negative. Let me give an example. Mother B, blood group O negative, and upon checking or testing the partner is, for example, blood group B positive. The children carry the DNA of the dad. So once your partner is blood group B positive, there are high chances, or I say it should be, that your baby is going to be rhesus positive. Remember, you are rhesus negative. So in simple layman's language, this is what happens. Your body is going to recognize that baby, that unborn baby, that fetus, as an enemy. We know about immune system.
Yes.
Of your body produces antibodies to fight the infection. So that is what is going to happen.
Your rhesus,
yeah, exactly, that is it. Your rhesus negative blood is going to produce antibodies to fight the rhesus positive baby that is in the inside of you. So upon fighting it, miscarriage. Or even when you're lucky enough, I don't know that I should call it lucky enough to carry it to term, baby is going to have complications. You understand me?
Yes.
Yes. So what happens, we all know, at least those ones that have gone a bit deep into health and science, that maternal blood and the fetus's blood do not mix. You have another pregnancy from probably some man that you would not want to bear for. It ends up being an ectopic again. You're losing the second tube.
I didn't know for ectopic pregnancies they always cut the tubes.
In most cases, they do. Because most mothers do not get to know about pregnancies until they see the signs and symptoms, until you've missed your periods and whatsoever. And ectopic, 2 weeks, you're already having pain on the side. You're having pain on the side, going to scan, ectopic. Some even end up taking painkillers, the pain subsides for some time, pregnancy is growing, causing more complication. The second misfortune about abortion is now the rhesus thing. You've had pregnancy maybe in school or campus or whatever, you do not want it,
Age
you abort it. You do not know that you're rhesus negative. You've gotten a good man, you've done the functions, you're in marriage, very stable marriage, very loving husband, you want to get pregnant. 1 month, baby is coming out. 2nd month, baby is coming out. You've gone to the herbalists, you've gone to Bamulerwa, you have done it all.
And it has not worked.
And it has not worked. It is rhesus. But like we said, the good news is we have solutions. Yes, as long as you detect early, there are solutions. So usually I'm having my couple, they want to give birth. We talked about all the other ones until
HIV,
now.
I hope you're taking note. HIV test, STDs, sickle cells, now rhesus compatibility.
Exactly. So I'm having my couple. I give my advice. I find out that Joan here is rhesus negative, and our dear husband is rhesus positive. The question would be, Musao, what do we do now about it?
Do we break up or continue?
The breakup is tough for those sickle cell people. Yeah, but for rhesus, at least science has provided solution. There's what we call the anti-D injection. Here we produce, they give you immunoglobulin. This injection will help neutralize these soldiers that we talked about and tell them, hey, calm down, it's okay. It is well. Yeah, so what we do is, my Joan is pregnant, rhesus negative. We get that injection at 28 weeks. That is approximately 7 months.
At 7
and
months.
34 weeks. That is towards childbirth. That is around A9.
But then my question now is, if we are getting it at 28 weeks, usually the baby doesn't last for 3 months. For 3 months after conception, when you're rhesus negative and maybe your baby is positive. So how do you handle that? Can you give it even before the 28 weeks?
The example that I gave of my Joanne, she's not aborted, she's O negative. It is her first time she's trying to get a baby. So remember, we said the first baby will survive. So with this first baby, we are getting it at 34. Sorry, at 28 and at 34.
Yeah.
The reason that's why we are getting it at that is because the placenta is getting bulky. There can be some rupture of some small blood vessels and blood can mix somewhere else somehow. Yeah, so that is why we are getting it at that time. Now, if it is a second baby, there are 3 scenarios where I can get that anti-D. One at 28, at 34, and 72 hours post-delivery. So I'm having my mother, now Joanne is sorted. Now I'm having my mother, they had their first child, probably in another marriage. Now she has come, I realize she's rhesus negative, and she hopes to get another baby. We give it as soon as possible.
Oh, so there is an option of getting it earlier.
Exactly, there's an option of getting it earlier. And one thing, you don't get one injection, because studies have it that this immunoglobulin, the anti-D, lasts in the maternal blood an approximate of 2 months. So that means usually they are to neutralize this mother's antibody, tell them it's okay, it's okay.
Okay.
You understand? So after we're getting those injections, the anti-D injections, then our baby is safe. And we get them every pregnancy. Because not only the second one. Every pregnancy, because remember we said it is short-lived, like any other drug. It will be administered, work for some time, and then it is done.
Back to normal.
Exactly. So we get them for every pregnancy. The first thing you do getting pregnant, probably you visited another midwife or guy that is working on you as per antenatal and whatsoever. The first thing you tell them, I'm O negative, I'm B negative, so that they plan for you. And there is also an exception of the mothers that are negative, second baby, but for some reason they were not briefed about rhesus from wherever they are, and then you get them exactly, and then you get them at let me say 30 weeks. This is the second baby. They have managed to carry it up to that time. Some even manage to carry it to term, and they deliver the baby, but the baby will have complications.
What are some of those complications?
Hearing disabilities, vision disabilities, mental disabilities, intellectual. They usually have very many cases of anemia, because the way it works is these soldiers that we talked about, they destroy the red blood cells of the baby. And that is anemia. So this baby is very anemic. This baby is very yellow due to its jaundice. They call it jaundice. Yeah, bilirubin accumulation. This baby is very yellow. This baby is very anemic. And the management after this baby is born is to try to, they call it transfusion. They put out all the blood from the body, and then they put another set of blood. Those things are done in India.
Oh, so it's not done here?
Not necessarily. As far as I know, probably maybe there are new researches, and I don't know what happens at Heart Institute.
Sounds very risky.
Exactly. Well. It is risky. Chances of success are low and expensive. So why would we wait to go to that? Yet we can deliver this information. Yeah. You know, when you know something, maybe the terms we've been using are kind of hard and you cannot explain it and whatsoever, just go to your midwife or to your gyne or to your doctor. Tell them, doctor, how about my blood group? Is there anything I need to know? Because I believe as long as someone has gone through med school, they have heard about this. So even if they do not know much, they will provide what they know. And we have Google.
Yeah, true. But then I'm also wondering, because this is information that I think most of our mothers or most of the people there listening might think it's for the new mothers. But if I'm already a first-time mother, what's the possibility that I've been informed about my blood group? Even if I've already given birth now, what are the chances that I know? Meaning it's important for us to as well go back and test.
Exactly. Exactly. You know, the challenge we have with the Black community, or I should say Ugandans, is that if I am fine, I don't feel pain anywhere, you think you're fine.
True.
We first wait for things to go.
Still, I get a fever. If they admit me, then I'm okay. I'm not
and
okay.
Men will go ahead to take a Panadol and they'll go to work. It's okay, I'm fine.
Anyway,
yeah.
Now, during pre-pregnancy, because we've talked about most of the things that we have to look at or look out for, even when we are going for pre-pregnancy counseling or preparation talks. One of the things that I know, I would love to know, what do I expect? What to expect in the pregnancy journey? I've had so many stories of bleeding during pregnancy, the complications that come in pregnancy. Those are the things that I want to, and I know some of my sisters out there want to know about, to understand why am I bleeding, yet I'm already pregnant. Because you'll find people that have been bleeding monthly, they think they are going through their menstruation period, yet they're actually pregnant. 4 months in, they go to test, they're telling you you're pregnant, but I've been having my period. So how does that work? What's the science there?
Well, I would want to encourage all our health workers to please do the service, do our patients a service of giving them the information. Something past just administering medication. Let us give the information and not wait for things to go out of hand and then it's saying you should have done this or whatever, because it's not reversible. Like if something happens, it has happened. If you have a wound, yes, it will heal, but it will leave a scar. So health workers, let us do this patient a service by giving the information. So when you are pregnant, number one, first of all, talking about bleeding, I do not expect you to bleed at whatever instance.
At whatever stage.
At whatever stage. There is an exception of what we call implantation bleeding.
What's that?
That is when the egg has been fertilized by the sperm and now it is going to settle in the uterus. So where it is settling, that area of attachment, there is some cells that are being washed away for this thing to attach.
Is that what we call the shedding? Or that's different? Because I've had so many times when it comes to that, someone says, you know, in the first 2 months or 1 month, it is okay to have some spotting. I think it's called spotting. Shedding, yes.
That is not the spotting, because that bleeding is very light blood. We regard it as pinkish. It is not serious blood. It is pinkish. And it happens for like 2-3 days, and then it is okay.
Can it happen every month or just the first month?
No, it cannot happen. You cannot, the fetus cannot be implanting every month. It's not possible.
So what's that bleeding that happens?
So the bleeding is signaling something is wrong. There is a problem somewhere. Science is very factual, but as a Christian, I would say there is that exception of God. Because as we are treating still and giving medication, expecting someone to be fine and then someone dies, God has done his thing. We have done our best. So that is the same thing. Someone will bleed and carry that pregnancy to term, but some other will bleed and not carry that pregnancy to term, or the pregnancy is having complications, or the baby after being born is having complications.
Yes.
There is a stage of the growing baby, initial stages. The first 3 months, meanwhile, in antenatal are very crucial. There is a stage where we see after fertilization has taken place, cell division, and we are having this cell as a whole. And once there is any trauma on this cell that is growing to become a baby, baby is having a heart defect. Baby is missing a limb. Baby is missing one eye, or the nose did not form. You understand? So if any of those things happen, now someone will tell you, I bled to this time. Meanwhile, it has happened to my mother, our last born. You know, she was thinking she's done with this, and then she bled for almost, she got to know the pregnancy when it is at 5 months. She told me, Tina, I was bleeding. Though she had issues with family planning, you know, that bleeding of family planning, uncoordinated, very irregular, and what. So she was like, Tina, I was bleeding. I got to know the month she was feeling ashamed. I'm like, it's okay, it happens. Like, I mean,
being 45 and you're telling your kid,
you know, I am having a baby. So she was very frustrated. I'm like, it's okay, it happens. You know, family planning has its own complications. It happens. And leaving the exception for God, it can happen, and it didn't create any serious effects. But there are cases whereby we are having defects as a result of that. I want to put it out in capital letters, bold, underlined, that any form of bleeding in pregnancy, please see your healthy worker, your doctor, your midwife, your gyne, as soon as possible. Let no one tell you that it is normal, because it's not.
It's not normal.
Even if it's the implantation bleeding I talked about, because you may not be able to differentiate it, whether it is implantation or it is whatever. Please visit your antenatal clinic.
Or even your doctor, in case you don't know.
Or even your doctor. Yeah, because there's also that part of consultation, on phone consultation. You may consult me and I'm frustrated.
Or you consult me and I say it's menstruation.
Exactly. I don't give you time to follow up and whatsoever. So come talk to me in person and ensure that I give you the time. Because on phone, you call me at 7 a.m., I slept at 6, and then I'm like, it's okay, you'll be fine. So any kind of bleeding, it can be as a result of placenta has not been embedded properly. Like, I don't want to go into that science. Placenta is supposed to be where, then it is embedded somewhere else, and then there are very many things. But for general knowledge, any kind of bleeding during pregnancy is abnormal.
What of the pains, the cramping that comes when you're pregnant?
The crampings are one of what we call the minor disorders of pregnancy. There are very many, and it is unfortunate. I worked somewhere and the midwives were not delivering this information, but mothers need to know. Cramping is one of the minor disorders. You know, when you're welcoming this baby into your body, everything changes.
True.
Beginning with your brain or your mental state, physiological state, every system in the body has to change to adapt to the visitor that we are having that is not going to go the next day. So the cramping is just as a result of hormones, and you know, it usually happens in the early months.
By early, you mean 1 to 3 or 1 to 5?
By early, I can mean 1 to 3. Some can get. Now, there is the cramping, but then there is also that pain, in between the groin area. That pain as a result of the pressure of the growing baby on the pelvis. So that pain is also there. There is also the pain of infection, because once we are pregnant, your immunity lowers a bit. When your immunity lowers a bit, the parts or the systems that are affected most, or that are easily affected, is the reproductive system for the females, because it is exposed, it is open, and then the respiratory system. Realize many mothers, they get a lot of flu-like symptoms during pregnancy, and also the UTIs. They are very common, because it becomes so moist down there, so it is easy to attract the whatever. So it can also be the cramping following the UTI. So there you cannot determine, because the mother will tell you, I'm cramping. They tell you, I'm having pain here. So it is upon you to differentiate, to follow up, ask questions. When do you get this pain? When did it start? Does it go sometimes? How does it feel for you to do? So there is that cramping as it of the pressure. There's a cramping of the UTI. There's a cramping of hormones, just hormones going here and there to make sure that baby's fitting.
Because most of the mothers that I talk to, the new mothers, she'll tell you, I've been cramping for a while now, but I'm scared of telling my midwife again because I'm becoming a problem.
Oh.
Every small cramp I'm calling, every small pain I'm calling, and they're telling me it's normal. The baby is growing. But then how do they know? Because now I might think it's normal, yet it's not. So when should I really talk to the doctor?
Especially for the new mothers, I personally enjoy to give them a lot of time. I go ahead to have a personal contact, like to share my contact with them. And I would want to take it in an ideal way that do not ever think that you're being disturbing or nagging. Especially me as a midwife, if it is concerning your pregnancy. Even if you wake up and your ear is paining, please call and consult. Why is my ear? Because you never know.
True.
The body is funny. So that pain, much as I have given the reasons that could be possible for that pain, I don't say do not report.
True.
Please report. Allow me go into this before we leave it entirely. There is what we call, I talked about the minor disorders, but let me deal with this before I talk about the minor disorders. Because we had a question of what should I expect?
Yeah.
There is what we call danger signs in pregnancy. These ones, first visit, first contact with the mother. Please let us deliver this information for the health practitioners. Number one is the bleeding we've talked about. Very keen. Your baby could be losing a part, an organ, or your baby could be leaving your body. So bleeding, I do not expect any kind of bleeding during pregnancy. Number two, the cramping. We call it LAP, lower abdominal pain in particular. We usually tell them, if you can work with it, you can be with it, because this is what we usually say, that if you can work with it, maybe it is the other pelvic pain that I talked about. But there are people who are strong and they will not give attention to their pain. It is much, but they can work with it. Exactly. Yes. Our tolerance levels are different. They can tolerate it. So report as soon as possible. And when you report, what is the midwife going to do after taking the history? Number one, they are going to do the tests. That is the urinalysis, checking urine and whatsoever. Number two is they will go for the scan. Those two at least will tell us where the problem is. Those two, and for the examination or the history taking also being part of it, they will tell us, is the baby coming out? Is the baby threatening to come out? Is it pelvic pain? Is it UTI pain? And then we manage accordingly. So number two danger sign is the lower abdominal pain or the cramping. Number three, any kind of fevers. I usually tell my mothers that when you're pregnant, you're not sick. And I usually tell them not to just be home and sit and do nothing and just throw yourself away because you're pregnant. You are not sick. So I do not, much as, remember I said there are minor disorders. Just a few things are getting different. But
Maybe
you're
not working as hard as you
Exactly.
used
I feel you get tired easily, your limbs are paining easily, you're throwing up, those symptoms of early pregnancy, you're feeling dizzy, sickish and whatsoever. Any kind of fevers, please see your health practitioner.
Okay. We're talking about some of the complications that may happen when you're pregnant. We're looking at how you, and also how you deal with them as a midwife. Now, I know the approaches are different. Could you briefly tell us the different approaches you take when you're handling such complications amongst adolescent mothers, then the young adult mothers, and then also the really old mothers, 35 and above?
Reproductive age is between 12 on average, and around 45 Most mothers are getting their menopause, like cessation of their menstruation, around 45 onwards. That is a reproductive age. So after knowing that reproductive age, that is where we group now. These are the young ones, middle age, and advanced age. The young adolescent mothers, I'll talk about now the mothers between 12 to around 20. And then the average middle age, we shall talk about 20 to around 30, early 30s. And then when we get to 35, now those are the elderly mothers. All these age groups have their issues, but one that is recommended to be very productive and to consider bringing a baby into the world is the middle age, between 20 and 30, early 30s, 34 and below. That is the time when your body is at its peak of reproduction. Everything is okay, everything is working well. Your body has literally prepared to have a baby and to bring it out in their healthy state. So that one doesn't have very many complications. The complications that may arise from that could be other factors like medical related. You're having your family history issues, you're having your personal medical issues, and whatsoever. Now I look at the adolescent mothers and the elderly mothers, that is 35 and above. One, the adolescent mothers, the biggest problem that their bodies are not fully prepared for the pregnancy state and the childbirth traumas and the postnatal of, we usually say a baby is taking care of a baby. So right away from carrying the pregnancy, it is hard. If you're to go psychological and mental, we're looking at stigma. This person has been in school and all of a sudden they're pregnant. They're not going to fit in school anymore. The friends, they're not fitting there anymore. The parents back home, some of them are chasing them away from home. So all this mental exhaustion and mental stress is on this mother. And like we always say that the condition, the stresses of the mother can always be carried to the baby. And once the baby cannot put them up, they're coming out.
Sure. Now, before we continue, because safe motherhood is really, really a wide topic. Maternal and child health is really wide and we cannot finish it all in one episode. Therefore, we're going to have a part B discussing more of antenatal care, handling all these complications as she was talking about, and then go further into childbirth. But for now, I hope you have learned, especially those in this age group. You're trying to start a family, please, before you even go for premarital counseling, please visit your doctor to get that pre-family and pre-pregnancy preparation talks with your doctor. Thank you so much. See you in the next episode.